Welcome back, everyone. I'm going to crack the whip and get on with the program. Sorry, everybody back in the room. So we're getting on to our second session, again, talking about the experiences of the Medication Reconciliation WHO High Five program. So we've again got quite a busy schedule. We're going to try and hold questions for the end with the panel. So if you've got a question from any of the presenters, please write it down so we can remember it towards the end. So our first presenter today, or on this session, is Dr. Treasure Maguire from the Mater Health Services, and she's going to talk about medication reconciliation, private versus public. Does it make a difference? Thanks.
Okay, so you've already met Daniel, our 60-year-old gentleman who came or hailed from our private hospital. He wasn't eligible for high fives because he was greater than 5 years, not admitted through the ED, and the intention of his stay was less than 24 hours. And you already know that a single source of medication was used for his first medication history, that when the surgeon was contacted for his night meds, again, a single source of information, and even though doses were adjusted, we still ended up with 2 medication discrepancies, unintentional, leading to a 20 times overdose and 2 nights in hospital. So keep that in the back of your mind when we look at the question about whether this misadventure would have occurred across the road in our public hospital and if a BPMH had been taken. So in the context of High Five, over this 4 to 5 year period, we've had approximately 10 hospitals contribute to the data, and most of these were public hospitals. There were a number of quality improvement measures that were captured during this time frame, and because we submitted our data to High Fives as a collective, what we wanted to do was pull this apart and see if we could answer the questions for our public versus private hospital if there was a difference. And to be able to do that, we actually had to understand the variables that underpin medication reconciliation in both of these settings. And it's something I'd probably not thought about during the 3 or 4 years till we had to put this presentation together. So there we are, sitting up in the middle of southeast Queensland, 1,000-bed hospital complex, both public and private, across the 3 domains of adults, mothers, and till the end of this month, children's as well, when we get the new Lady Salento Children's Hospital in Queensland Health. So we thought we're in a good position to answer this question. And when we thought about it, there were basically 4 parameters that were likely to impact as variables on this question of public versus private. The patient cohort themselves, the health professional that individually conducts the MedRec, the medical model and the pharmacy model. All of those contribute to those MRs. So think about the patient cohort for the project. Initially we thought, well, it's going to be the same. They're the same inclusion criteria. But when you consider public versus private patients, there tends to be in our public cohort more social issues. There's certainly a difference in socio-demographics, education, and with our private cohort we tend to have a higher use of complementary medicines. So they're not quite the same animal, but pretty close. What about the health professional conducting the BPMH? In the private system, the health professional tends to have access to less information, both from the VMO and from the GP. And a cost-effective BPMH is going to depend upon, I think, 3 things. The medication skill base of the individual conducting the BPMH, their willingness to source more than one, source of information, and their inherent communication skills. So if you look at Daniel's case, the nursing staff that recorded the first medication history only used one source, which was patient recall. And neither the prescriber nor the nurse who administered the overdose of clonazepam were familiar with this drug, the dose range, and didn't check it in a single information source. What about the medical model? So at our private hospital, there is, as Tanya mentioned, a general reluctance of nursing and medical staff to conduct a formal BPMH. And we did an in-house survey about this and found that there was a perception of insufficient time to invest in the activity. In terms of surveying our nurses, the initial med history is about a 2 to 3 minute activity rather than the longer time that's needed for a BPMH. The private VMOs have less time for writing scripts, also for documenting care plans. And this may well be a choice on their part, but the fact remains less time is invested in the process. And one of the things that we thought was really quite interesting, we wanted to share, is that there's an increased reliance on phone orders. And so there's a requirement for a good memory on behalf of the VMO, and maybe we don't always get things on memory right. The VMO certainly appreciated the pharmacist's role in BPMH to the point where they wanted us to complete this before they would write up the medication chart, and in fact some of them wanted us to do that for them as well. So if Daniel had been in our public system, he would have been captured at pre-admission, and the BPMH would have been available during and post-surgery. But this is missing. We have a pre-admission clinic, a welcome lounge, but only for patients that are intended to be admitted, not for day cases. And so this is a gap that wouldn't have been picked up through this project. The fourth variable was the pharmacy model. So what we've done here is compared MATA public with MATA private and alternative private models. And I guess we're very blessed in my complex in that the public and private model of pharmacy care is not hugely dissimilar. We have a clinical service with our pharmacists spending about 85% of their day in the wards. There's on-site dispensing from the ward, and the staffing levels are not hugely different between public and private. That may not be the case if you are a remote pharmacy servicing a private hospital, where you might be supplying on script or on chart, and your staff numbers are going to be based on script volume. So even with pretty good comparable services, we would still have missed Daniel in terms of capturing his first medication history. In the context of integrity and quality transfer of information, we do have an electronic pharmaceutical care plan, and it's both our, our saving grace and our nemesis, as I'll explain. So we've used this for a decade or more. Very difficult when the medication action plan came into place, which was a hard copy, to move away from a fully automated electronic system. So what it does is it captures the admission list and the patient demographics, so it makes it very easy for the pharmacist to capture that initial information. Drugs on admission can be added fairly easily, and that can be formatted in a way that's more user-friendly for the patient or for the ward. Patient-specific tasks are captured, so we know for this patient whether we need to be monitoring their INR, their renal function, whatever. And we could very easily adapt this to incorporate whether a BPMH had been recorded within the first 24 hours or not. So it responds very well to new changes in patient-specific tasks. The data rolls over automatically in preparing the patient's drugs for discharge, and every step of that patient's journey from admission to discharge is captured. So it sounds like the greatest thing since sliced bread, but it has a problem. And the problem is it's a pharmacy-driven system. It's not a hospital-wide, accessible electronic medication management plan, which means that every time we make a change, we have to download another hard copy to incorporate within the patient's medical notes. And so that, to me, is one of its really major disadvantages, and we're hoping that will change, as Tanya mentioned, within the next 12 months. So, knowing our system, how do we perform on MedRec public versus private? We capture MR0, and we do this because, as we've already alluded to, this is predominantly a pharmacist-driven activity. And we wanted to know, before there was a formal BPMH, how many discrepancies in normal activity we were picking up. And you can see that whether it's public is Mater Adult Hospital, the blue, the red is Mater Private Hospital, that on average we are in normal pharmacist activities picking up about 4 medication related discrepancies, whether they're intentional or unintentional. In terms of MR1, so what you've got on each of these following slides is the data that we send through to Hi-Fi's, and that is an amalgam of public and private. So we're a single site in terms of Hi-Fi, which is why we'd never actually separated and looked at public versus private before. And then on the larger graph, you've got, again, blue public versus red private. And we are certainly doing a little better in terms of MR1 in our public, but it's not hugely dissimilar, but a little better in the public versus the private system for capturing the first BPMH. What about MR2? Despite the fact that we are an outlier hospital, and part of that we think is because we've had a complementary medicines policy and an active role in thinking CAMs are an important part of the patient's medication history, both in terms of efficacy and in terms of potential adverse effects. So we were over capturing that data, and that came up quite a lot with the intentional discrepancies. But again, if you compare public versus private, it's not that dissimilar. More importantly, when we look at MR3 and MR4, these are very, very similar, aren't they? And this is our important outcome or output data. So MR3, the mean number of outstanding unintentional discrepancies per patient, and MR4. So we felt in the context of the SOP, whilst it's met many of our needs, but over the 4 years we picked up probably 2 key limitations, and one was that there was very much a focus on entry into the SOP via the emergency department. And you can see from Daniel that some patients do slip through the net. And secondly, the lack of consensus for individual medications like CAMs and some of the PRNs, particularly if they were unrelated to the episode of care. So in conclusion, what we found from separating out our public and private data is that we do a little better in the public system total quantum of BPMH, but for the quality measures, MR2, 3, 4 and 0, these were very comparable between our public and our private setting. And if you think about those variables of difference in model, then you really need, if you're going to achieve similar results in public and private, to adhere or to satisfy 3 criteria. And the first is to have a model and staff that support BPMH. And I think that's come through in all of the talks so far, and it probably will continue through the afternoon. That they're willing to take time to access resources for a double check, and that the health professional conducting the BPMH in any transition of care has to have a good working knowledge of not just medication available, but their dose forms, their strengths, their dose ranges, the usual doses. And I guess for me to answer the panel question that was posed earlier is we should have the profession that best fits the task do the task. And nobody actually mentioned that maybe pharmacists should be in the public and private setting 24 hours a day like many of our other colleagues. And I think that probably would be the most important intervention and outcome that could come from the findings of High Five. Thank you.
Thank you. Sticking right to time, we're going to move on to the next speaker, Gabrielle Couch, who comes from the Southern New South Wales Local Health District, who's going to give us a rural perspective.
Figure out how to drive this. Thank you. I'd like to thank Helen for offering me an airfare to come here today, but I didn't deserve it for two reasons. One is that we don't really have an airport, and the second one is that we pulled out of this study. So I do apologise on both accounts that, and forgive me, it meant I had to get up really early and drive. So. When we were all one big happy family in southern New South Wales, we gathered 8 hospitals together to try and make up a critical mass so that we could work like a larger hospital. And we so considered ourselves a single site, if you like, and collected data from July, the pilot month, through to September. And we used the hospitals only that had clinical pharmacy services. Some of those were outreach services, and some of those were not full-time services. But we weren't looking at hospitals that did not have a pharmacist on site. In only 3 of those hospitals were there any non-VMOs, that is, junior medical staff, and the remainder were GP VMO hospitals. So we knew that already we had quite a different sort of mix compared to perhaps some other larger places. We were also very keen early on to look at what we felt was the most important problem, which was were we focusing sufficiently on the sorts of problems that happen on discharge. So we straight away started to collect data on discrepancies at discharge at the time that we started the study. Sadly, we did have to discontinue, and mainly it was the difficulty in trying to get enough patients to meet the X equals, I think, 30 a month or something like that, by using patients that had been seen within 24 hours, admitted through the ED and aged over 75. That just required such an audit burden to try and exclude the patients that hadn't been seen within 24 hours. We felt that we could no longer continue. But as you can see from the data, I think it was a great exercise from our point of view. So there was a fair bit of workload also trying to get an independent observer in to verify, given that some of our sites had sole pharmacists. So the data here shows that we were consistently doing pretty well early on, and we were very keen to see what number of patients were actually receiving MedRec in our hospitals at all, and that was consistently over 80% in the hospitals with clinical pharmacy services. Then the percentage of patients that had been seen within 24 hours, again, a pretty good 50 or so percent. And as you can see from the trends here, nothing's really changed particularly over time, for the time period for that survey period anyway. When we look at the key indicator, which I think is the MR3, is number of unintentional discrepancies per patient, you'll notice that things went a bit awry around Christmas. That quite often happens, but apart from that, we tended to sit under the benchmark. But importantly, as you can see, the purple line there is the sorts of problems that we were experiencing on discharge and wide variability in that setting as well. So just wanted to spend a bit of time talking about how we managed to verify our medicines, because we are not great users of the MMP, although 2 sites were using it at the time. For a lot of sites, the front of the drug chart was used by clinical pharmacists and continues to be, particularly in smaller hospitals, the red box, and that is a legitimate place for recording verified medicines histories. We had widespread use of Medical Director, which is our GP prescribing software we've been using in our hospitals for many years. So depending on the choice of the individual hospitals, that might have been their source or the output that we used to document our verified medicines. And then in terms of the how we verify, we were consistent with the protocol in terms of using either the traditional pharmacist approach with a source plus one, or if you didn't have a pharmacist on site and you were looking at a record that a doctor had written up on admission, if there was at that stage a second source of information where you could see that it had been used to verify the prescribed medicines, that was counted as a verified drug history. So, for example, and we've had a fair bit of discussion with Helen about it at the time, if a medication list had come from a GP letter had come from the surgery, had been scribbled on and said this is nonsense, this is right, and that sort of thing. So that was taken as a verified source, even if the VMO had written it up, rather than there having to be a formal MMP completed on admission. So what's different in small hospitals? I guess the main thing is that we've got less steps between the GP surgery and the inpatient stay. So in some ways there's less opportunity for things to go wrong, and the quality of the information in a smaller place can be a lot better. We also have good liaison with our community pharmacies in small towns, and they're very used to us calling them several times a day. So if you're in Queanbeyan, there's 5 pharmacies. If you're in Cooma, there's 2. So they pretty well get to know that this is something that we're going to ask them several times a day. Group GP practices, I found, have really got their act together, particularly if you get into these super clinics now, which we've got a few of, and there's very good transmission of information from the GP surgery to the hospital, and of course we could spend a lot of time talking about the quality of that information, but the fact that it is routinely transmitted certainly helps us. Similarly, in some of our facilities, but less so these days, I think because of the advent of smartphones, our GP VMOs in some places were accessing their own GP software from within the hospital and then transmitting information back to their surgeries, so that you were having, really quite seamless flow of information about changes to meds, theoretically. Because we get quite a lot of people coming in from another hospital, Canberra sends us a lot of patients, for example, and then we get a lot of people coming to and fro from residential care facilities. They're quite reliable sources of information about what's gone on immediately prior to a person's episode of care, though again there may be changes that haven't been picked up at that stage. Helen had suggested that we spend a bit of time talking about how we then took that information and incorporated it into our standard for activities for accreditation. We've just been through accreditation in southern New South Wales facilities, and they didn't detect any problems, so we dodged a bullet, I guess, so I'm not quite sure, but we did quite well. So we'd already been doing, as you can see from the data that we had a pretty standard process that had been working pretty well. We wanted to see if we could extend that high five process, incorporating the key questions into the wretched medication chart audits that we were doing anyway. So we added these extra lines to actually give us an incentive, if nothing more, to complete those audits. And what we systematically do now is we actually take reports of patients that have been discharged, post-discharge, with a length of stay greater than 24 hours. We have a pharmacist plus one doing those audits, and we ask questions about the rate of clinical pharmacy services, medrec within 24 hours, and provision of discharge information. Now, this happens in all our hospitals, and it's routinely incorporated into our accreditation activities now. Now, since High Five, we've actually moved more in some of our facilities to a electronic medical record. And I've got this statement called forcing function if the EMR is being used. What that really means is that if we're participating in the process of entering medicines information into what we use in New South Wales, Cerner, and that's going to be then sucked up into the discharge summary, if we're part of that process, it's forcing us to actually do it, get our act together, and maximise how many people we do that for, and making sure that the information that's incorporated into the discharge summary is correct at the time of discharge. Okay, so here's some data from our last, from 2003-2004. And it gives you an idea of the range of clinical pharmacy services that we have in all our hospitals in southern New South Wales. And this is, again, pulling discharged records for patients with a length of stay greater than 24 hours, adults and children. And this is the percentage of patients that have been reviewed by a clinical pharmacist. And so, I'm sorry that's cut off down. Oh, no, you can see it there. Average in the larger sites actually is not hugely different from the average overall. But, yeah, 76% of patients are being seen by a clinical pharmacist. So when we're doing these audits, we then ask whether the medication history was confirmed and documented, and those results there of 68%, and interestingly, well, maybe not interestingly, average in the larger sites is less, but perhaps because we've got people coming in for surgery that stay for longer than 24 hours, and obstetrics and different things like that, where they may not be seeing a clinical pharmacist as often. There's an extra column over there, February 2014, and this is to show you what will happen if you lose a staff member in a small hospital. You can go from having an excellent service to having almost no service simply because you've lost, half or all of your clinical pharmacy service over a particular period of time. Some of those sites are actually MPSs. That's multi-purpose centres where we've got long-stay residential patients coexisting with acute care patients or patients transitioning into residential care. You can. What we're actually asking is that there be an active medication care plan for all of those patients, and again, that's very much dependent on whether there's a clinical pharmacy service. The second line there, Bombala, with a day a fortnight, went from no service in June to a full service in October, simply because somebody was employed and then started to go there. So this is what we're really looking at, and we knew that we were very poor at documenting a routine clinical pharmacist activity, which was providing information to patients on discharge. Had a bit of a talk about it, and we thought, well, we'll either just put a copy of the medicines list into the clinical record at the time, or we'll have something on the medication chart that documents that we provided information to the patient. It wasn't good enough to simply say that we were there or that we'd seen the chart. We were saying, yes, we gave medicines information to the patient. And so that's, as we know, with the mantra that's used a lot in quality improvement activities, if it's not in the clinical record, it didn't happen. So we're getting pretty good results there in both June and October, and we're doing another round of auditing roundabout now. So we're planning to do this approximately every 6 months, irrespective of whether the accreditors are stalking the corridors or not. I just wanted to talk a little bit about the way. I'm sorry, that's a little bit fuzzy and hard to read, but this is an output from the Medical Director GP prescribing software. And what it is a medication management plan that can be generated on admission. And this little bit up here changes to medicines since admission is really where a summary of what might happen on the MMP is documented. It's documented very quickly. We don't document what's already true. We're actually talking about what's changed rather than spending a lot of time in documenting stuff that is already correct. Then there's a summary of information about why the patient's in and why and their past medical history. But down the bottom, the plan, that will change over time, and what we will tend to do if a patient's been in for several days, there might be 2 or 3 of these things coexisting in the clinical record, like Treasure was saying. So it's a dynamic document that then gets generated at discharge, is sent off to the next point of care. The same information is used to generate the discharge medicines list because it comes out of the information system. And we've just found out a way, Andrew, for us to take this information and copy it into PowerChart, into the EMR, so that it actually becomes a document sitting in EMR that's called discharge information. So there are other ways of doing that, and of course in the hospitals that have JMOs that are actually busily generating their own discharge plans, they're going to do this with using typing, which is what I call the lack of a database in our EMR, where we don't have any drug support or any drug information, so people just have to type the information in for better or for worse. So the other thing that's important about this is that I've got hard-coded into here all the hospitals, all the pharmacies that are associated with those hospitals, all the pharmacists that work in the hospitals, the numbers, the phone numbers for and the fax numbers for mental health or community health or other people that need to receive these bits of information, so that you can then generate, using the template, a highly specific document from this hard-coded information that we keep up to date. And so, yeah, thanks to everybody. It was a lovely, brief journey through High Five, and certainly it's helped focus our attention on the need to be more visible in the clinical record, definitely to be more accountable, and that we are actively moving away from using any hard copy MMPs and trying to encourage everybody to use an electronic solution, be that the GP software or the electronic medical record with all its warts and lack of a database. And we're continuing to measure those key outcome measures. Thank you.
Thank you very much. We're moving on to the next presentation. Now we're going to have a slight variation in the schedule. We're going to hear from Catherine McVeigh and Dana Strumpman from Prince of Wales Hospital first, and then we will hear from Anne Whitaker and Deb Miller. And they're going to talk about medication reconciliation. Whose job is it anyway? Thanks.
Okay, hello. Just wanted to thank all the hospitals. We've really enjoyed the journey and we've learnt a lot from all the participating hospitals, and a special thanks to Margaret and Helen. Thank you very much for all your advice and support and encouragement, and you really were only a phone call away during the last 4 years. So 4 years on, and the Prince of Wales High Five team wanted to know what clinicians thought about whose responsibility medication reconciliation is. So our baseline data from 2010 showed that pharmacists alone could only reconcile 35% of patients within 48 hours. We really did have insufficient pharmacists to maintain and sustain MedRec. And we realised then that we needed to implement a multidisciplinary process. So we began initial training by training pharmacists, and then got them to train teams on the wards, and got them to try and to customise the way wards did their processes. We also took MedRec to grand rounds and ICU grand rounds, and initially there was a lot of resistance from clinicians because they didn't see how MedRec would be able to solve the medication problems that we had in the hospital. Since then, we've been doing ongoing training. We've been going every year to JMO orientation, registrar orientation, and resident training, and we've showed them how to do best possible medication history and showed them the medication reconciliation process. We've also started going to medical intern pre-registration workshops, and we've incorporated into pharmacist orientation. We also have been going to new grad nursing training, where we've tried to show them what the MMP is and how they could help with medication reconciliation by medicine matching. So when we did in 2010, when we did with the High Fives, the patient safety culture survey, the biggest single problem identified by JMOs was that things fall through the cracks from time to time. With the implementation of the High Five SOP, we hope that our hospital's patient safety culture would improve. And we wanted to know whether our approach did in fact involve any of the multidisciplinary team, was anybody but pharmacy using the MMP, and were there any other barriers that we didn't know about? So we decided, so in 2011 we implemented a multidisciplinary approach to MedRec, and by June that year, we achieved 60% of patients over 65 having medicines reconciled within 24 hours. But in 2011, we went down to 25%, and there were a few reasons, the most important of which was because they implemented electronic documentation in ED, so there was duplication. The electronic version didn't have functionality for medication reconciliation, so pharmacists were doing it on paper form, and it was really, really difficult to get the doctors to document the medication history in electronic documentation and on the MMP. So it became a pharmacist-only process. So in 2014, we wanted to know whether our patient safety culture changed for the better, and if anybody but pharmacists were even looking at it. So we did a survey with Redlands Hospital, and the primary objective was to find out whether clinicians understand the importance of medication reconciliation, who should do it, how it should be done, and why it is important. We also wanted to find out if there were any barriers to implementing this practice, and also if there were any barriers that we didn't know about that could be overcome or resolved in the future. So, as I said, we did the survey with Redlands Hospital, which was really good, and we surveyed doctors, pharmacists and nurses and collected data over 7 days because we only decided to do the survey really late. So we gave out, pharmacists helped us give out paper forms, and we emailed, and they completed the survey through SurveyMonkey, and we got the pharmacists to really try and get doctors and nurses to complete it, and we got 138 responses. So only 12% of the total, of the total number of doctors responded, 5% of nurses, and 75% of pharmacists. Which was but then when you look at the total number of responses, almost 50% were nurses, and 36% were doctors, and only 17% were pharmacists, so pharmacists didn't really skew the results. So when we asked, did they receive education on MedRec, 53% said that they hadn't received this training at orientation. So although we didn't reach everybody, they said that when we did reach them, the quality was good. So it wasn't always accessible, but the quality was sufficient. When we asked who's responsible for completing the medication management plan, only pharmacists were united in saying that it was everybody's job. We still hadn't been able to sell that message to other clinicians. So when we asked what you understand the main reason for medication reconciliation is, everyone seemed to have a good grasp of how MedRec improves patient safety. So when we asked, can you remember when MedRec helped you to pick up a medication error? And we were really surprised by this answer because we didn't think other clinicians were looking at the MMP. And 90% of doctors said they could remember a time when MedRec helped them pick up an error. So that was quite a surprising result. And most of the clinicians said that the MMP helped their team to make safe decisions for their patients. So overall, comments were mixed. Doctors said it's a great initiative, please keep it going. Nurses said some education would be good so we can use it more effectively on ward rounds. And the pharmacists lamented, only pharmacists are doing MMPs. So the barriers identified from the survey is, although we were really trying hard, we still don't reach all clinicians with education. Time to complete the education is a barrier, and also prioritising it, especially during orientation. Some of our successes is that it really has been, people are aware that it is a patient safety. It does improve patient safety. And although the multidisciplinary approach was identified, it's a bit ambiguous about whose responsibility it is. So limitations in the study were, we wish that we had more time to have more responses. We were hoping to have more doctor responses, and we're aware that it's just a qualitative study and only shows clinicians' attitudes only. So what do we need for future success? We feel we need to develop a strategy to engage and involve senior clinicians to understand their role and responsibility in advancing MedRec in their department and across the hospital. We need electronic tools that support the High 5 SOP, because we know it's a really good, robust SOP, and we're working with EMM people to try and incorporate all the steps. When we first started, we felt Prince of Wales wasn't really ready for implementation of MedRec, but this is slowly changing with the incorporation of MedRec into the standards. You really need good physician champions to help sell to medical officers, and we're lucky to have two. Isella's here from the ED department and Catherine from aged care, and they really helped to try and persuade and definitely did in their areas, but we really need physician champions in every area to help improve our MedRec.
Okay. Thank you very much for asking me to come and speak and to be able to bag out my fellow doctors. There's not too many in the audience, I don't think, and that says a lot. So, look, you'll see here, these are just things that I've heard personally myself, and this will not surprise you. It's very interesting because doctors think that they're the only people that are busy in the hospital, but that's one of the things you hear all the time. Why can't the pharmacist just do it? Again, but it's not our problem. It means writing things out multiple times. What's the point of it? And why don't we just wait until electronic prescribing comes in? You know, you've heard all of these things, and that's mostly from the doctors. I think one of the biggest issues is actually sort of capturing the correct audience. As we've seen earlier, a lot of junior doctors, once that's explained to them, do see the benefit of it, but we're really missing that middle level, the staff specialists, the VMOs, etc. They don't really seem to think that it's actually their issue. They don't prescribe drugs, you know, on a day-to-day basis, so it's not their issue. We've seen earlier that the IT systems often don't speak to each other. So, I mean, it just does make life much more complicated. You know, when you have a mixture of paper and electronic notes, it is a shambles. We need a change in attitude. Doctors don't change attitudes overnight. We are very rigid, and it does take time. And I think, as it was mentioned earlier, we have to chip away, slowly but surely. And I suppose just one of the biggest barriers that we find is that the senior staff don't really realise the importance of the process. When we went into grand rounds initially many years ago and presented a couple of cases similar to the ones that you would have seen earlier, the senior staff specialists were like, God, our junior doctors are terrible. You know, they didn't seem to think that it should be driven from them or that they should be checking medications. It was just, oh, right, okay, so it's important, is it? So that's one of the things that we've struggled with. So again, this will not surprise you much, that there's the old hierarchies and the professional boundaries, and it can result in disagreements about where the responsibility lies. But I suppose if we try to actually focus and get everybody's mindset that it's about reducing patient risk and increasing the information that's available, then surely these barriers can be put aside and people can work together to try and get the best outcomes for the patient. Competing demands and the common response that we don't know where to start. It's too big. It's too overwhelming, and that, you know, it is a big challenge to do something like this. It's a big deal, and it can lead to delays in getting things started. And again, we can't underestimate the support from managers, the senior staff, to try and enable the good folk on the ground to try and prioritise this as part of their workload. And, you know, put this into sort of a part of the everyday process for the organisation. So this pyramid here is not just related to medication safety, but it makes a bit of sense. So I think just for any problem to try and resolve it, you have to make sure everyone understands what the problem is, then empower teams to do great work, in turn to create a better design and development life cycle, communicate better, we all know that, and then prove it works. So I think that's, you know, a good simple way to think of the problem. There's no shortcuts to breaking down silos. This is something that will take time. You can't fix the environment if the organisation doesn't understand the problem. You can't improve the development process if the right systems aren't in place. So climb the pyramid brick by brick to the ultimate goal. And again, we always have to be having this at the forefront of our mind. It's better clinical outcomes through collaboration. And again, I think there's a talk later on about from one of the consumer representatives, but there hasn't been a lot of chat earlier, but we really can't forget about the patients, and they have a responsibility as well. So the value of involving the patients and their care in MedRec really can't be underestimated. They are a valuable source of information about what they take with support, and they can be encouraged and enabled to be more active in the process. And I think that really is something that we need to get into the community and get recognised. Or from the organisational perspective, the profile still needs to be right up at the top. We do need the senior executives and the management to take the lead and promote medications reconciliation. Again, we're here today to have a collaborative approach and learn from others, and again, that's very important. I think we all patients are the same, no matter what hospital you're in. Medications are the same. We can all learn from each other. And if we get the process right before instituting EMM, you know, that's, again, another message to get across. It's detrimental to put bad stuff into a good system, and the system is only good as the information that is put into it. So it's not the response for the juniors doctors earlier on, why can't we just wait for the EMM? It's not going to be the panacea. We're still responsible for actually doing our bit. So guess what? It's your job, and that probably sounds bad because the majority of your pharmacists, but I meant it to be. It's everybody's job. And I didn't mention in the last slide that all of the third years from UNSW come through our unit every year, and they don't get out without having 2.5 hours of being locked in a room with me to get taught fairly comprehensively on taking the best possible medical history, and they go through the MMP, and they get to fill it out. They get to prescribe on a medication chart. It's double Dutch to them. They've never heard it before. But they enjoy it immensely, and I think what people were saying earlier is you have to capture the doctors when they're young before they get into bad habits, and if it's ingrained into them from a very early stage. And I frighten the bejesus out of them by saying, you are putting your name on a chart and it's prescribed. It is your responsibility as a doctor. It is not the nurse's responsibility, the pharmacist. If anything happens, the shit stops with you. And I think doctors get away with it. They write these things down, and it's a legal document, so I do frighten them, and it does seem to work, but maybe that's not the PC way to do it. But I think it's really important that doctors do take ownership and take responsibility, that if they're actually the ones that are writing it down on the chart, they should be taking the history and be quite happy with what they're prescribing. So that would be my perspective. Okay, thank you.
Okay, so we might run a little bit over time. I apologise for that. So we will be presenting a similar perspective, but from the Queensland version. So it's still looking at how to make the MAP, which is, well, that's what we call the Medication Action Plan, which is the Medication Management Plan in other places, how to make that multidisciplinary and our journey for that. So before getting started, I need to tell you a little bit about the history of the MAP at Redlands. We were one of the lucky few to be one of the pilot sites in Queensland Health. Back in 2005. That was back when it was a single-page map form, so it has progressed a little bit since then. It has been around in our site for at least 9 years, so we're quite used to it. Around that time as well, we implemented an emergency department pharmacist, and she's been quite integral in making sure that process happens. When we joined High Fives in 2010, pretty much it just gave us extra ammunition, and this meant promoting it to the multidisciplinary team, getting the message out there, trying to get some buy-in and some help out with it. We're quite fortunate now that about 90 to 95% of our patients admitted do have a MAP form or BPMH, not all within 24 hours or even 48 hours, but the fact that they're getting that service is quite a good thing, we think. And obviously, as with every other site, the fast turnaround times, which are only getting faster, they're becoming a big problem for us. Our MAP form is incorporated into the eLMS software program. Those of you in Queensland Health will know what that one is. I'll show you a picture in a tick. This is a great software program. It's integrated in with the electronic discharge summary from the doctor's perspective. We can import information from our dispensing system and things like that. So it's quite a good little program. And we can use this to generate all of our discharge summaries, our medication, action plans, everything. It's wonderful. This helps us to do our discharge medication reconciliation. We can create our inpatient, our leave discharge medication records from it. We also have a nifty tool called the interim medication administration record. So that goes out to the nursing homes. I've got a picture of that in a tick, and it's 5 days of like a interim medication chart. So it's providing that continuity of care before the GP can necessarily get out there. It's also used in pre-admission clinic, where we create a record there and then the doctors there use it to prescribe on the NIMC, and it's also used in our dialysis unit as well. So that's what it looks like. You can see, let me see if I can get the pointer to work. Yep, so you can enter each individual medication in there with the changes, the directions, all these other things, stop, cease information, and then that goes to generate these things. So that's a discharge summary. It looks very similar to your also your inpatient record, your leave record, those kind of things. That's the interim medication administration record, so it looks like the medication chart. And then that's the electronic version of the MAP form, so it looks almost identical. So where we're at now is that our BPMHs are documented pretty much consistently by all the pharmacists and Deb, our wonderful nurse. We have quite a few reasons for that, which we'll go into a bit later on. If we get to the BPMHs in emergency, then they form the basis for the prescribing on the NIMC, and the emergency doctors and the med regs are very, very keen to get that information, get their hands on that, because obviously that saves them work. Unfortunately, despite our best efforts, the majority of the multidisciplinary team aren't contributing to the BPMH, but they are contributing to the front of the map, so the issues page. So we see that as a win. It's not the win that we were originally hoping for, but it's still a win. And then once these issues have been raised, they generally get answered on the map form as well. So generally we need to contact people and say, just have a look at the map and kind of prompt them to actually look at it rather than them individually doing it themselves. But again, we feel it's good. So here are just some real-life examples of some multidisciplinary mapping, as we call it. So we've got a few there from nursing staff, one there about the Webster pack that was a social worker, enteral feeds from the dietitian, speech pathology about swallowing. So you can see we've got quite a few good examples, and yeah, there are many, many more that I could have added to this list. So where we'd like to be at, which is something Deb will talk about in a little bit more detail, we would like everybody to be contributing to the BPMH. We've heard about all of the challenges and things, and obviously we all have our own versions of that as well. But we would like, instead of nursing staff writing things in the columns on the OBS form or randomly in the progress notes that you can never find again or on a post-it note, this is what we want. So things like, patients on warfarin, because if that's your best possible medication history, then that is your best possible medication history. That's all you've got time to do, then that's great. And that's still more than what we knew without that written down. So I'll hand over to Deb for the next section.
Hello, my name's Deb. So how have we got to where we are today? We did want to include all disciplines, and as Anna's just said, that there have been inputs on the issues from speech pathologist dietitians, but we thought that we would focus our efforts on the medical and the nursing staff, and with the orientation competencies and some training. And the aims were multifocal, really. We wanted to make sure that people didn't. It was to raise awareness of the map, because it had been sort of in place for quite a while, and to make people understand that we weren't expecting them to do a clinical pharmacist review, but it was to get the process rolling of making a list, to use the form for what it was meant for, and also to use it for any issues, so that we weren't sort of getting into that post-it note culture as well. So we had a couple of doctors on board, one of whom was in a training role, and so he was looking after some training competencies for the doctors for the best possible medication history. And Anne set up a one-day training course for 10 nurses from the emergency department. They weren't exactly pressed men or women. They weren't exactly volunteers either. But they were quite carefully selected, and we used a combination of Medication Services Queensland and some local resources, and it was a combination of theory and practical stuff that occurred on the day. So we had an MSQ BPMH video, how to actually take it, and they were actors, but they were pharmacists and nurses playing the roles of pharmacists and patients. Some instructions on how to map and how to reconcile as well. There was some names changed, but some examples of real-life situations. Lillian was a lady who was meant to be on thyroxine, but it got missed, and Bruce was a gentleman who was discharged home without his warfarin and the consequences of that. And we went through some of the common BPMH traps. So the patient, are you on any medications? Patient says, here's my Webster pack, but then they don't tell you about the 3 puffers that they're on for their asthma or emphysema, and they don't tell you about the once-a-week medication for osteoporosis or the 3-monthly injection that the doctor gives them. Medication resources, so getting the GP letter, faxing the community pharmacist, a little bit of role-playing, and some supervised practice. So pharmacists took the nurses down either to the wards or into emergency and had a go at actually writing the best possible medication history. And then Anne did one-on-one competency assessments with the nurses afterwards. And the feedback from the day was really good. It ranged from, yes, it was really fun, to they enjoyed the practical aspects of it. Nurses are very practical people. It was good to understand those real-life situations and the effects of omitting or adding in unnecessary medications, important for patient safety, etc. But has this changed the practice? And yeah, in practice, I have to say probably no, but it has most certainly raised everybody's awareness of the map and the importance of making a list. So we keep going on, and we jump on every possible promotional opportunity that we can. We've presented at grand rounds. Lillian and Bruce raised their heads again. We've presented at departmental business meetings. We've had posters, badges, stickers. We have a dedicated window in the pharmacy that sometimes they're just fairly general things, or sometimes they're fairly specific, who needs to really do what. And we've been really well supported by the executive and by departmental heads. So we've featured in newsletters, and they were quite pleased with the People's Choice of Our Snakes and Ladders poster 3 years ago. We've done mail-outs to the GPs and to the community pharmacists. And the pharmacists have also presented. And this conference poster here, this is from 2 years ago, and they did both admission medrec and the discharge medrec as well. We've used a lot of the NPS materials, and here is our shopping queen for NPS. So if any of you out there have had problems getting any of their materials, it's probably because Anna snaffled them all up in advance. We've had Medication Action Plan Month, foyer display, which is featured just there, in-services, screensavers, posters and badges. That's we've made a lot of use of the match-up match-up medicines stuff that we've been given. That's just an example of one of our screensavers. and Medication Safety Month. And although it's sort of medications and pharmacy as a whole, we always make sure that we've had some of the high five medication reconciliation stuff up there as well. Probably the biggest enabler for us at the moment and for ongoing medication reconciliation is for it to be included in accreditation, and it is the medication reconciliation, not just the best possible medication history. Within Metro South, which is our area, one of the clinical government's key performance indicators is medication reconciliation within 24 hours over weekends. But at the moment, we only have a clinical pharmacist doing that on a Saturday. But it's obviously in their mind, so at some point, hopefully, the funding will be there. And then there's the clinical pharmacist standards as to SHPA and ClinCat. And as somebody else mentioned, the forcing functions, and they do work. I say we do still keep going in emergency, even though the uptake hasn't been that good with people actually writing best possible medication lists. But in every triage folder, there's a map. They're available on all the wards and on all the pharmacy trolleys as well. And we're just trying very hard to build that mapping culture of asking the doctors, have you checked the map? A map has been written. Okay, here's the medication chart, but you haven't included a medication that was on the map. And our admitting doctors in the hospital will now often request a map before they do start to write their medication chart. Oops. And I'll just hand back over to Anne. Oops. Sorry.
Sorry, I hope you don't come and tackle me. I only have a couple more slides left. We started late. So after all this, what do our staff actually think? And so this is building on the survey that we did with Dana and Catherine. And so we surveyed the 15 doctors, 23 RNs, 4 CNs and 4 ENs. And I haven't split up anything for the disciplines because we found that the results were pretty much exactly the same. So not unsurprisingly, the bits that are most useful to people are the BPMH and... okay, good. Oh, right. Sorry. The BPMH and the changes were the most useful, so that's really good because that's what we kind of expected to see. 97% of people say that the map form significantly helps to make safe clinical decisions, so there's a lot of love there. On discharge, they probably don't see the discharge medication reconciliation side of things because that happens in the pharmacy, but yeah, clearly they do feel it does help generally. And most people said that they refer to the map at least once during admission, and 32% of staff said once a day they look at it. So that's really good as well. By and large, the majority of people said it was a multidisciplinary approach, and it's good to note here that this were just nurses and doctors. We specifically decided to exclude our pharmacists because we knew that they would skew the results, and I really wanted to know what everybody else thought. And 56% of staff said that if there wasn't a map, they would chase down the ward pharmacist and get that sorted out. So people say that the map form is very important in minimising and preventing medication errors. 82% does help to make safer clinical decisions, and a large proportion, so up to almost 60% of people can remember a specific time, if not more than one, when the map form has prevented an error. And clearly patient safety wins out in the end, so that's always helpful. So a lot of love, very useful tool. It's very useful for us doctors, but aware that it's a lot of work for you pharmacists, as we've heard already. They are good, I depend on them, and it's a godsend. So people really love the map, which is nice. Hopefully they weren't just being nice to us in the survey. But having said all of this, it still is only just the pharmacist and Deb who document the BPMH on the map. So why is this so? Oh. So we've heard already, medical doctors, it's hard to sustain. It's another form. They're already writing them in the progress notes and the NIMC, so effectively this could be a third form for them. Time, workload constraints, it's easier just to quickly jot everything down in the progress notes rather than finding that extra extra map. To go to a separate form would interrupt their workflow process in the progress notes, and we also have new staff every 10 to 12 weeks, so that makes sustainability very hard from our perspective. And it's different from pretty much everywhere else, so no other hospital does it the way we do it, is the response we get back all the time. And unfortunately it's still seen as a pharmacy form, which we're really trying to change. So in 2012 we did a just survey looking at the barriers to the MAP form. Of course, won out. We've heard this time and time again. Pretty much people said, yeah, need more time and need more pharmacists. 2014, nothing has changed. It's still time and workload. And a lot of the nursing staff actually said that they wanted more training. So that's good. Maybe that's something we can look at in the future. So where else from here? We will continue using it. We will continue promoting it. Unfortunately, time equals money. Time is what you need to perform a good BPMH and complete the map form. But that's all about resourcing. So again, I'm sounding like a broken record compared to everybody else. We will continue to improve efficiencies within our service. So one of the things we're looking at is our NEAT target has dropped, unfortunately. We're now sitting at 67%. So one of the things that we're looking at to help with that is actually to increase our pharmacist service in the emergency department to decrease the workload on the doctors and hopefully move people to the wards faster. And we're also taking up the pharmacist prescribing pilot, which is a very new, exciting venture. So we'll have an ED pharmacist and a PAC pharmacist doing that. Because we know that many hands make lighter work, and we're going to keep aiming for utopia where everyone maps. And we're going to keep promoting it. After this conference, we've been asked to present at the Metro South Safety Board on the interim report and discuss the findings with that. So it's very high up on executive radar, which is really nice. A nice little note to end on. How long does it take to form a habit? Well, 21 days if you've had a limb amputated. It can take 18 to 254 days to form a new habit, but the map form, we're still counting, 9 years and counting, so we'll get there. It's just a matter of time. And I'd just like to acknowledge everybody who has supported us in this venture. It's been a long, hard road, but it's been worthwhile. Thank you.
Okay. Well, thank you. We're running a bit behind time now. I'm afraid we are going to be eating into lunch. So we'll just have to compact things down a little bit. Our next presentation, Medication Reconciliation, Tracking the Patient Journey, Linda Graham. Thank you. I'll speak quickly. No, you're fine.
Okay. Thanks very much. I'm very privileged to have worked in two very good teaching hospitals, one in Sydney at Prince of Wales and Sydney Children's Hospital, and now I'm at the Alfred in Melbourne. So I've got a very good, I think, overview of MedRec in two states. But I'll be talking about Alfred Health, and Helen's asked me to also talk about Alfred Health and our MedRec process, and also the patient journeys, which is what I was originally my original theme. So I'm not going to go through the process. We've gone through that quite a lot. We all know that reconciliation on admission decreases harm, and even if you have an electronic generated medication list, errors happen. So it's not just the electronics, it's the actual what you do with the electronics. So this is what the patient was supposed to have. So it's not just about the list. So my theme is about the patient journey. So we get the value added by actually listening to the patients rather than just looking at all our pieces of paper or the electronic data. So we are a recent ED shift I thought I'll collect a few patient stories. So this little Greek lady came in with some AF, and she brought in her medications. But I said, well, is this all the medications you're on? Well, I actually take Pradaxa as well, but I stopped taking it a few days ago because I saw this television program where people were bleeding, and I don't really know why I'm on it anyway. So this was an opportunity to talk about Pradaxa, to talk about her medications and a bit of communication. How about allergies? That's one of my interests. Any allergies or reactions to medicines? This lady was post-chemotherapy. She came into the ED with neutropenia. She said last admission she had a terrible rash, and the doctors all came in, and this is her words, they all came into the room and waffled something about all these names of antibiotics, and off they went. And she didn't end up knowing what antibiotics she was actually allergic to. So I'll just divert a bit more a bit at the moment and talk about the Alfred experience, because I've been really interested to hear about how everyone's using the high five and how everyone's doing MedRec around and adapting it to hospital situations. Fantastic. So this is our experience. So clinical pharmacy services, as we've heard, is usually 5 days a week. And MedRec is recognised as core practice for Alfred Health clinical pharmacists since 2003, so over 10 years. So we've been doing it for a long, long time, and it is pharmacy, a specialised area for pharmacists. It's requested by nursing and medical staff pre-admission. Often in the ED, the nursing staff will page us and say, can you do a med rec, please, because we don't know what the patient's on. And on weekends, when we do our weekend shift, it's a priority. We do all new admissions and we review their medications as a priority. And lately we've been focusing on med rec in the ED. So we've seen this graph and we are that blue outlier up the top there. And that's because of our pharmacy services and our emphasis on ED. So a further emphasis on the ED came about with the previous speaker mentioned the NEAT targets. So we put a package, Gen Med and ED put a package together called Timely Quality Care. And it was really meeting the 4-hour rule. But we put it together, you can't read it up there, but it's not just about getting patients out of the ED, but it's about restructuring the ED processes and the admission process in general. So we don't have a triage nurse anymore, we have a consultant that actually triages patients and makes a decision, takes bloods and does whatever's necessary, and then the patient either goes to short stay, gets admitted, or is on fast track to go back home. So we're meeting our targets fairly well. So there's a few other quality things we restructured and did, and part of that was funding for an extra ED pharmacist. So our ED in general, our weekend clinical pharmacy services started about 2009 in general medicine because of a study we did showing that all the interventions that general medical pharmacists do on ward rounds. This has expanded to all areas at the Alfred, so we had weekend cover to all the clinical areas. And this year we've restructured that so that we actually have pharmacists attached to medical teams, just like the doctors do on the weekends. We have a pharmacist attached to certain medical or surgical teams on the weekends. So let's look at ED pharmacy services at the Alfred. So we had in 2010, actually I started in 2010 at the Alfred. So we had a pharmacist that came down on the weekend to the ED sometimes, and then they covered a whole lot of other areas. In 2011, we had one ED pharmacist, so did a weekend shift both days, 8:30 to 4, which is our weekend hours. And then with the Timely Quality Care funding, we increased our services to the ED. And since then, we have 3 ED pharmacists, not all at once, but we cover the from ED handover, which happens at the Alfred from 7 a.m, and then a new pharmacist comes on at midday, and then a pharmacist comes on for 3 p.m. handover. So we have 3 pharmacists covering that time period from 7 in the morning till 9 at night. And then same with that funding, we had to give them something, had to give them some value added to the pharmacy service in the ED and Gen Med. And so the pharmacist actually charts the medications after reconciliation. So we're using our med reconciliation form, and we're doing the same process, following the SOP that we all know. But then we discuss with the med team, are you okay if we chart all this? Do you want some VT prophylaxis? Do you want to stop anything, start anything? And then we go ahead and chart. And that's a credentialed thing for ED pharmacists. So you have to be credentialed before you can work in the ED. The other thing we've just started this year, not much to do with MedRec, although it has actually, we credentialed to attend stroke call-outs. So the aim of this was to get a medication history for stroke patients as quickly as possible before we thrombolise them. So we're not thrombolising people that are on antiplatelet agents, so the doctor can review all their therapy before thrombolysis. So this is what our weekend roster looks like. It's a bit of a headache for all concerned. As you can see, the red is 3 ED pharmacists, and the rest are the other hospital staff, pharmacy staff that go in the dispensary, sterile preps, and the clinical services. You might see, in 2015, we're just about to add another pharmacist on the weekend. I think I circled it, called the discharge pharmacist. So I think we've heard from several areas, which I was interested in as well, about pharmacists putting medications in the dispensary. So to do that, we realised we had to have an extra person on the weekend to look at the people discharged on weekends. So we're just working about that, and that'll be implemented shortly. Anyway, so let's get back to our patient journey. This is the emergency department list, or a list. It's electronic. It helps and assists us prioritising our patients when we come on for our shift. It doesn't just do that. It's not just a list. It generates reports. It generates annotating that anywhere or noting it down. So she had a experience last time. This time it's a good journey. This was her MedRec we have a MedRec form that I completed in my beautiful handwriting. She came in. She was transferred to our rehab hospital just for about a week. There were changes in therapy, as you can see again, beautiful handwritten notes. However, it is electronically scanned into the medical record. So I could find what happened in our rehab hospital. It talked about changes. Plavix was ceased because she had falls and she was late 90s. She probably won't need her Plavix. Her daughter did request no clexane, no bloods, and that was respected. So that was fantastic that she didn't have any pathology during that week taken, and no VT prophylaxis, and she was discharged. So the discharge process is very complex. I think we've heard everyone's looking at discharges now, and concurrently with the high five, we've also been looking at our discharge process at the Alfred. So as you can see in the red, we've got a handwritten script. We have a discharge letter, which is electronic. We have an MRF, which is handwritten but then scanned. We have a written prescription, and we have PBS paperwork, an iPharmacy computer program, which generates the medication list, which of course doesn't talk to the Cerner power chart, which is the medication record. So we have got a bit of everything. So it's wonderful that Mrs. MW actually went home with a list and her discharge summary. So we thought at the time, this year we were testing those indicators that Helen mentioned earlier, or was it Margaret? And we saw that our medication list wasn't terrific. Our rate of accurate and complete medication list wasn't terrific. It was about 38%, even with all our pharmacy staff out there in the wards. But that was, the medication list, of course, was completed by the doctors on discharge. So why was this? Well, we had a whole committee looking at it, and we noted that the templates varied. Some people just had free-flowing lists. Some people had a typed summary. The summaries weren't done in a timely fashion. We had a KPI. They had to be done within a month, so that wasn't very timely for the GP. The orthopods didn't even bother writing anything in the medication area or ADRs or anything at all. So everything was quite different as a whole. Dog's breakfast, as Liz used to say. So we thought we'd do some improvements, and we've already instigated a template, which this is Mrs. MW's template that she went home on. Very clear, as you can see, the medications are there, what was started, what was ceased, and her allergy or her sensitivity to opioids is all listed, so that was fantastic. And increased timeliness. So for Gen Med patients now, they get their discharge summary on discharge in their hand. And we found on audit it's about up to 80% that actually happens, whereas for the other ones with all the different templates it's 30%. So we have improved that, and we're going further with that. So we want to see this very complex paper electronic-based thing going to a very simplified one summary from the treating team, getting all the information to whoever needs it, whether it's the pharmacist, the patient, and also generating the data that we need for KPIs, any research we're doing, and looking for incidents and coding for ADEs and ADRs, things like that. So wouldn't that be fantastic? So I thought I'd just finish off on looking at patient-centred care and the use of technology, which we'll be talking about in the afternoon, which I'll be really interested in as well. So this slide was taken with permission from David Greenfield. He presented at ISQA last year. And as you can see, when I finished, and Gay and Lorraine finished university in 1970s, there was nothing about patient-centred care in Medline. There was nothing. Nobody was interested in the patients. We were all interested in all sorts of other things. But this has sort of grown exponentially, especially in the last decade. So this is where we're going. And as you know, there's a lot of different publications now. We've got the WHO, very interested. We've got America and all sorts of organisations. We've got, of course, NPS has always been very heavily patient-centred. and of course our own commission, and our standard 2 which is partnering consumers. So we really got to move away from our lists and our other things into partnering with consumers, and that's a great step forward. I was just looking in other areas, what other areas are doing. So in America, they've got these high caps that an external surveyor has these standard surveys to look at the patient's experience, and then hospitals benchmark against each other how good they are, which they like doing in America. But they want to create a national standard for collecting and reporting these patient perspectives. So not just satisfaction, what's the food good, and how do you feel about it, but specific outcomes, yes, no, or numbers. So specific outcomes about the patient experience. The other thing that they talked a lot about at the ISCA conference this year was patient-reported outcomes. So we're not just asking patients once they go home whether they're feeling good or if someone talked to them, but actually they go to these desktops or portable devices and put in their outcomes. So in this example is in the rheumatology clinic, how many joints are hurting, what's your pain score, how have you been since last time, are you taking your medicine? So they put all that data in. It goes into a central data bank. The clinic physician can have a look at it. You can have a look at the medication history. You can chart graphically outcomes, and you can track things. It's all electronic. It's all in one database. And then there's a feedback system. The patient can look on a website and say, oh, yes, that's my information and that's how I'm going. So it's a patient-physician sort of thing. So we're already using this in our ED. We're using things like electronic databases to get our data and also to track the patient's journey. So it's not far to go to think technology can help us the next step along. So for patients, something like this, giving them this while they're waiting in the ED to come in, to write in their medications and their information or what they're feeling like. Technology can help with languages. We have a lot of non-English speakers, and give feedback to us. And for the clinicians to give real-time data from the patient, give us some measures of how we're going, some feedback, reporting, all that sort of stuff. It's already being used, and we just had to really adapt it. So medication reconciliation and beyond. So I've got this systematic review from Kaboli. I think Margaret put in one of her presentations previously. The 5 things that are evidence-based that pharmacists' interventions make a difference. And all the ones I highlight, there are 5 of them that he listed, and all 5 have got something to do with the patient. So they're all in red. So reconciling, medications up there up the top, and doing all that other stuff that clinical pharmacists do. So that's why we really, in the Alfred, we think pharmacists, like Tricia said, pharmacists are the specialists in this area, and we're really the ones who have to do the reconciling. So that's sort of our way of looking at it. So best possible medication history. Again, someone mentioned that it does depend on for us, it depends on the patient. So they have to take a bit of responsibility to maintain that up-to-date list and bring in their medications and tell us about what's concerning them. How could we track the patient's journey? So we should do the review from the patient's perspective, as I mentioned those few quotes at the beginning of this talk, about what they felt, what they know, why they're not taking their medications and so on, to get a full story. Maybe we can set up a survey with the patients about, did you speak to a pharmacist? Do you remember doing, did you have a chance to ask questions? Things like that we could put in a database and see how we're tracking, how the patient's tracking our journey. So, in conclusion, medication reconciliation is part of the patient's healthcare journey, and patients are getting more and more involved in their management. They're getting more and more using technology that we have, and we have to give patients the tools. And I know NPS has done that with their apps, and we need to train, we need more trained staff. So whether you want to train nurses or pharmacists, that's what we need, as has been described. Advancing technology can help this process, and patient input improves their journey by highlighting the gaps in our processes and facilitating change. So ask the patients, get their feedback and facilitate change in your area. So that's my last slide. I thought that's a great graphic, very colourful, and that's the reference. So thank you.
Thank you very much. Our final speaker for this morning is Patty Warne, who comes from the Consumers Health Forum of Australia and also representation on the Medication Reference Group here as well. So very involved. Thank you.
I'd like to thank Helen Stark and Margaret Dewgood for being such wonderful midwives to the High Five project and for nurturing, I dare not say, wet nursing participants through the process of the results we can now see. And I also say I appreciated Tanya's colour-coded discharge dressing map, and I appreciated Catherine McVeigh and Linda's comments on the patient journey. For those of you who don't know me, I worked for various Commonwealth Ministers for Health and Community Services. I've had 10 years as a mental health visitor and aged care board member, as well as a bit of personal experience as an ordinary carer and visitor to friends and relatives in hospitals, aged care and palliative care. So I do know the hazards of transitions of care. I've actually been to 3 funerals in the last fortnight, one for a 69-year-old friend in Hobart, diagnosed 18 months ago with throat cancer complicated by HPV, one for a 98-year-old man who introduced Medibank a long time ago and who I worked for 40 years ago, and one for a 77-year-old man who'd spent the last 6 months of his life in hospice care with brain cancer. I have observed the way many people interact with the health system, and I think I can say what some consumers would like because they've told me, informed by their pain, discomfort, frustration, and yes, gratitude. We all subscribe to the mantra, first do no harm, but before anyone gets a chance to do any good or harm to someone who's sick, can we first be treated as individuals? Taking a best possible medical history is clearly very important, but before we get to hospital, we need to get some things straight. Whether you're a doctor, nurse or pharmacist, try to understand that we may be worried, speechless or bewildered when you first encounter us, especially in emergency. Notice whether we can actually hear what you're telling us about our condition or the questions you're asking. Think about whether we could ever actually see the instructions on medications we've been taking or that you might change for us. And if we can see them, whether we can read and understand them, because our reading age might be lower than you imagine and our comprehension limited even if our first language is English. And notice whether our fingers are gnarled with arthritis or trembling with Parkinson's, which would mean we would have great difficulty opening bottles or packets of tablets. And when taking a BPMH, remember that we really might not be able to remember what we've been taking and why that might be so. This is all part of meeting us halfway as individuals who want to be made better, or at least to suffer less through your care. The NPS has done valuable work on helping people to be medicine-wise, especially with the medicines list, when it's available. And we would like you to be sensibly honest with us. Tell us, write down for us what the medication is supposed to do. Tell us that the tablet for blood pressure is to stop us having a stroke. Tell us why it's important to take tablets in a particular order at a particular time with or without a particular food or drink. Tell us not to use other people's medications and why. And in this day and age, tell us not to sell our painkillers to the local bikies to supplement our pension. On the same tack, in case we are so poor as to have to decide with or without a higher co-payment which scripts to fill in which order because we can't afford all of them at once, tell us which one matters most so that we can make an informed, if foolish, decision. And let's not forget the meds people stop taking because they can't stand them, because they can't afford or can't get to a pharmacy for repeat scripts, or because they've heard the publicity about overuse of antibiotics, and think they're doing the right thing by not taking them after they feel better. I think of two people I know. The 91-year-old lady treated initially with antibiotics and regular dressings for 3 weeks for a skin injury on her leg, but whose infection was belatedly established to be MRSA, resulting in a change of medication, something she didn't think to mention when taken from her home to emergency with a lung infection, but which I was able to pass on after she'd had 4 days in a 4-bed ward in a suburban hospital. Not that anyone seemed bothered by this, although she was then moved to a single room. Conversely, the lady I know whose recurrent UTIs saw her on a constant round of antibiotics prescribed by her GP for months, in whom she had great faith, but who had never actually asked her for a urine test. When her husband called an ambulance when she became delirious, subsequent tests and scans established that she'd had a malfunctioning kidney for her whole life. When it was successfully removed, she had no more UTIs. She's currently somewhere on the Mediterranean on a cruise. But she maintains faith in her GP because he's such a nice chap, and he tells her all about his bird-watching excursions to obscure countries all over the world. We're all aware of the unfortunate side effects that are accepted as part and parcel of treatment for many conditions. Anyone who's worked in mental health or aged care has seen patients so spaced out they can't function, who are piling on weight leading to diabetes and heart problems, who complain of their heads exploding when they take certain antipsychotics, who are constantly chewing or drooling with distressing skin complaints, or whose gait is so compromised that they're at risk of serious harm from falls. Leaving aside the challenge of mental health, ageing, dementia, health economics and an inadequate care workforce, there is also an ongoing ethical issue around prescription medication. So tell us that there are recognised side effects and what they might be. Ask us to be aware of any reactions to medication and to tell our doctor or pharmacist about them, so anything unusual can be reported to relevant authorities, because better records on side effects will help all of us, pharmaceutical companies included, I might add, to do no further harm. Encourage us to be collaborators in our treatment wherever possible, not just passive consumers. Consider whether there's any degree of informed consent about taking prescribed medications if you don't level with us about what they're expected to do and what the complications and consequences might be for us if something goes wrong. I referred earlier to my friend Michael, who was given a pessimistic prognosis from the start of his treatment for throat cancer 18 months ago, with an initial 12.5-hour operation followed by radiation and ever-changing medication for complications of diabetes, DVT, cellulitis, and hardly surprisingly, depression and pain. And he experienced very many transitions of care in those 18 months. An intelligent person and a gifted communicator, he meticulously documented his particular patient journey by blog and Facebook whenever he could, which was just about every day, noting and commenting on his experience of his treatment, his reaction to procedures and constantly changing medications, his fluctuating moods and his small and large frustrations, bewilderment, questioning, anger, and gratitude for the relief experienced through kindness, as well as competence in his carers. His treating team had regarded him as an unusually focused and informed patient, but quickly realised that he was giving them a priceless gift in terms of an individual reaction to a rigorous and in some ways an experimental journey that lasted longer than anyone expected. They were prepared to alter, moderate, recalibrate his regime in response to what he was telling him about what was and wasn't working for him, by extrapolation, how others might be affected. Much of what he wrote has been incorporated into teaching materials for medical and nursing staff and students at St Vincent's and Peter Mac in Melbourne, and lessons learned adopted by a collaborative team in Hobart in the later stages of his life. So this is what I think consumers would like: to be treated like Michael, first and last, as individuals, fellow travellers and contributors on what is often a long and painful progress towards a kind of healing. And a best possible medical history is really important in that process. Thank you very much.
Thank you very much for sharing that with us, Patty. That was wonderful. And on that note, I think we'll go to lunch. Please find the speakers and ask questions and discuss what we've talked about this morning. I'm afraid we're not going to have time for questions now, but hopefully we'll all do it over lunch. Thank you very much.